So the I've got some data that I have pulled up, and part of it is so that we can talk about what you can meaningfully do versus what you may have learned with respect to claims. Right. So a lot of the claims that you'll hear when doing cranial type stuff is you'll hear about balancing the autonomic nervous system or improving function of varying systems. That sounds fair to what your experience is so far. Sounds fair. Yeah. So if you look at CV4, does anybody remember CV4? Compression of the fourth ventricle. So basically on the occiput you hold, and the concept is that you would utilize pressure on the occiput to compress that. Now it does live in front of the cerebellum, so there's a distance thing there, but there's the claim that because of anatomical proximity to the occiput, that you can compress the fourth ventricle, do something positive to the cerebrospinous fluid, and as a result of that, you should see change in autonomic type function, right? Because the cerebrospinous fluid's through the brain and the entire spinal cord, so that's how it should work. So I'll go through some data just so that you have it. One of the students who has graduated did CV4 and then measured heart rate, blood pressure, so systolic and diastolic. The average heart rate change in a negative direction or a positive direction, it dropped. So an average 3.3 beats per minute drop, right? I would argue that is not impressive. Because exercise across time, blood pressure medications can do stuff like that and better, right? The average change for systolic blood pressure was 5.75 millimeters of mercury. So let's just say you go from 120 to 114.25. Not that big a deal, right? The average diastolic is 1.8. So you go from 80 to 98.2. Or sorry, 80. So 80 to 78.2. I can't do math all the time. We have cervical treatment just treating the cervical column, right? So treating the cervical column, you would assume because of the the carotid sinus, where the baroreceptor reflex lives, that you would have a positive impact on blood pressure if you altered pressure through the region. The average change in heart rate is 2.52 beats per minute. So it's smaller than if you do CV4. So that's interesting. If you look at systolic, it's 2.7 millimeters of mercury. So drop 2.7. So you go from 120 to what would that be? 117.3? Is that what it would be? I think so. Average diastolic is 1.82. So 78 point. Whatever. I'm going to mess that up. 18. I don't know. I think it would be 78.18 millimeters of mercury. So if you compare that to a control group, control will on average go up 0.3 beats per minute. Systolic change will go up 0.06 millimeters of mercury, so nothing. So these are larger than if you do nothing to somebody, but I don't think they're large enough to be clinically relevant. You have an average increase on diastolic of 0.18 millimeters of mercury. So then we had somebody who did treating the thoracic region and the hip, right? So we have an average increase of average drop treating the thoracic region of 1 beat per minute. That's an average drop, okay? So it's like, if I go from the base of the skull to the thorax, it seems to get less. So there is some pattern there that actually shows that it might matter where you treat if you're concerned about heart rate and blood pressure. Then we had an average drop in diastolic or systolic pressure of 0.2 millimeters of mercury. This is nothing. It's barely better than control. And then an average drop of diastolic of 1.167. Then we had the hip. So they treated the hip, same person treated the hip, just to compare what would happen. We have an average increase of 0.33 beats per minute. So you go from 90 to 90.33. So I was like, kind of does nothing. So treating the hip kind of does nothing. Then it's an average increase in millimeters of mercury systolic of 0.6. So you go from 120 to 120.6. I can end up making sure that you guys have this if you care about these details. Then the average the average change in diastolic is 0.7, goes up 0.73. So it would go from 80 to 80.73. So again, this is like, okay, so it matters where I treat if I'm concerned about heart rate and blood pressure, right? And it seems to be the closer I am to the head, the better it is. What that would do is it would give you some confidence that if you make the claim neurologically that the neck and the head matter, okay, they matter more than the hip for heart rate and blood pressure. So for regulation of systemic pressure, because I'm going to measure systemic pressure usually on the arm, something's there, right? We had prone oscillation. For those of you who have experienced prone oscillation educationally, the claim generally is that prone oscillation should balance the autonomic nervous system. So what you would want to see from that, or generally what you would assume you would see, is heart rate and blood pressure lowering. Fair? Right? What we see is average BPM change of prone oscillation is 0.1 beat per minute lower. So you would go from, say, 70 to 79.9. Okay? That's average, but there is an interesting swing. So I don't have the information about min, max for the other ones in this chart, but I'll put it in later. The largest drop in beats per minute for prone oscillation was 16. The largest increase was 30. And the average is 0.1. So what that tells you is that it's all over the place, right? So prone oscillation, if you're concerned about the autonomic nervous system, you have no idea what it's going to do, which way it's going to go. It's all over the place, right? So as far as blood pressure is concerned, an average increase of 0.05. So you would go from, for systolic, so you'd go from 120 to 120.05 on average. But we did have, what was the biggest increase? We had the biggest increase was 18 millimeters of mercury. So you would go, say, 120 to 138. And the biggest drop was 19. Sorry, the biggest increase, no, hold on. You would go from 120 to 102, right? So that's the good direction. The bad direction is the number I have here that's negative. So it's 19 millimeters of mercury rising. So you'd go from 120 to 139, right? So if you wanted to manage blood pressure, prone oscillation, as far as what we've seen, is not the way. You have an average diastolic change of 1.45. So you'd go from 80 to 81.45. Biggest drop is 11 millimeters of mercury. So you'd go from 80 to, what would that be, 69. And then average or biggest increase would be 11 millimeters of mercury as well. So you would go from 80 to 91. Now, something's happening, but it's not trustworthy. So one of the things that we want to consider with what we claim, with what we do, is level of accuracy to what we can observe. Most of us in day-to-day practice won't take heart rate and blood pressure. It's not something we'll do, right? Because partially it's cumbersome, right? When you're experimenting, it's very cumbersome because you're using a shoulder girdle. So you're like, okay, well, I got to figure out which shoulder to put this on so that it doesn't get in the way. Right? So measuring these things is cumbersome. The patient experience, not the most enjoyable. I mean, most of us, when we go to our physician for our physical and they take our blood pressure, it's not that enjoyable. You know, sometimes your arms go numb. Sometimes it's just white coat syndrome. So you go into a place where somebody has some official capacity and it's like, well, my blood pressure went up, so I don't know what you want. So they'll have you come back and remeasure sometimes. The lack of measurement means we get a lack of feedback. But because most of us have been told by the culture of our profession that these things happen, we assume that they do, right? We assume that we're calming somebody down. Well, if you're calming somebody down, generally speaking, you would want to know where they are and where they go. And easy measurements that are proxies for the autonomic nervous system are heart rate and blood pressure. They're right there. They're not perfect, but they're there. They will oscillate normally, but they don't oscillate a ton. We know that from our controls. But then when we look at how we apply things to it, it matters where you treat, and it matters how you do it to some degree. So prone oscillation, not very good. Like major swings. Working on the hip does kind of nothing. Working on the T-spine kind of does nothing as an average, but working on the head and the neck seems like it does something. So if you're relatively smooth and calm in your approach and you pay attention to how the person responds, working the base of the skull or the neck does something for heart rate and blood pressure. So we sort of start to have an idea of where we can go if we wanted these things to happen with some reliability, right? I can trust that it's likely going to do this. Whereas with other ones, you can't necessarily trust. It'll go all over the place. And for the most part, most of the experiments that are ongoing right now, that's what we're getting. Results are all over the place. There's some terms that some people are going to be more familiar with than others, and it's terms in medical ethics, right? This is just really, really quick. Educationally, do you remember speaking about medical ethics? Did they specifically speak about non-maleficence, beneficence, autonomy, and justice? No, for you, yes. I'm talking to the other folks. No, fair enough. My recollection is that those terms were not discussed. The general behavior being respectful and responsible, protecting privacy, yes. Right. So non-maleficence, most of us will have heard the term, the Latin primum non nocere, or first do no harm. It's the central thing in the Hippocratic Oath. So what you want to do is make a choice whereby if you have a target, you have reason to believe that it will not harm that person. It will not make you go the opposite direction of the target, right? So if your target is dropping heart rate and blood pressure, you already know that prone oscillation is not your move. You already know that treating the hip is not your move. You already know treating the thorax is not your move. You could work the base of the skull and the neck. You have reason to believe that you have some trustworthy positive outcomes as a result of those, right? So we have non-maleficence, first do no harm. Then we have beneficence. Beneficence comes after. So first, do no harm. Beneficence is choose something that should do what you want, should go the proper direction. So again, if we have some target and we measure that target, we know the rates, we can start to know the rates at which things are going to happen in a certain way. So when you see average calculations, you don't see the swings. Right? If you're reading something and you know what to look out for with respect to standard deviation, the larger the standard deviation, the larger the swings in the data, right? So the farther apart the top and the bottom are. But that's not what you get taught. You don't get taught with those pieces of information because it seems like those pieces of information aren't being collected. And if they're not being collected, well, how do you figure it out? You kind of don't. So at least in a very, very small way, if we're talking about heart rate and blood pressure, if we're talking about the nervous system in and of itself, we can start to think that, okay, base of skull, maybe. Neck, maybe. Everything else, no. Right? So we can start to see that there's probably some benefit for those things if we work here. So at least, say for myself, who's somebody who has challenges and vocalizes those challenges with the claims of cranial approaches, I have some information now to say, you know what? Maybe I can calm down a little bit because maybe it does more than other things. For calming a patient down, for balancing the nervous system, balancing is probably the wrong term, but for activating the parasympathetic nervous system, it seems like there's something there. Now, you have to be careful with the terms because there's some old osteopathic books that will talk about things like inhibiting the phrenic nerve, so inhibiting the phrenic nerve, if you were to inhibit the phrenic nerve, your prediction is that your breathing should slow down, which under certain circumstances sounds like a really good idea. If somebody's hyperventilating and you grab their SCM and hold it, probably not going to calm them down, right? There is inhibiting the vagus nerve, which is here. So they go to the SC joint and they hold. So you're inhibiting the vagus nerve. Now, when you inhibit the vagus nerve, you should see heart rate and blood pressure goes up. But in my experience, you see the exact opposite. If you go to the SC joint and you hold there, heart rate and blood pressure go down. They go down to a floor and they float up, and they go down to a floor and they float up, and they kind of hit a floor and they float up, and my memory of the term is vagal escape. So you get that. Then you'll see this with paramedics. When they want to stimulate the vagus nerve, they tend to go up by the mastoid process, and they do essentially a vagal massage. So they'll use their knuckles and they'll just rub around the mastoid process. And the idea is to really irritate the vagus so that you get the heart rate to drop. Now, paramedics, as far as I know, do that, and it works to some degree sometimes. Right? So if you look at old osteopathic books, you'll see them differentiating. Now, anatomically speaking, how in the heck do you differentiate from mastoid to SC the difference between the vagus and the phrenic? As far as I know, you don't. Because now the phrenic is technically outside of the carotid sheath, if I remember properly, while the vagus is inside of the carotid sheath. But I can only be outside of both of those things. I can grab the SCM and hope that they don't feel like I'm trying to choke them. Right? That's my hope. So there's something there. You get some effect. And we know that you get some effect on, say, vagal tone by treating the neck or treating the base of the skull. We know that. Or we know it with some reasonable level of confidence because we can see it in the data that students have collected. Right? So we want to be careful with respect to what we claim. So the new data that I have allows me to calm down a little bit about the cranial claims with respect to the parasympathetic nervous system. It's like, I guess I can buy this a little bit better. I still have a hard time with claims about cerebrospinous fluid. Like I definitely do. But it doesn't mean that you can't shift my opinion, because with data, I will shift, right? It doesn't mean I buy most of what cranial approaches say, but it does mean that I'm more open to accepting that it does something more positive for heart rate and blood pressure as a parasympathetic proxy measurement than other things, right? So I'm more okay with that than I used to be, but that's because we're actually observing it. But when somebody tries to tell you that you go to another area of the body and because you're, let's just say, using rate, rhythm, and repetition to calm the sympathetics in the T-spine, no. Just absolutely no. Prone oscillation, because that is one of the ways you will use rate, rhythm, and repetition to calm the sympathetics in the T-spine. I see nothing. I see that it goes all over the place. So does it have an impact? Yes, it has an impact. Does it have a reliable, trustworthy, clear direction of impact? No, it goes all over the place. I don't know how and I don't know why. Yes, please.
With these experiments, are you doing, let's say, individualized treatment on a specific body part?
So,
regardless of what the individual is presenting? Is that
so it's not necessarily, it depends on the specific experiment. It's going to be set up according to a prediction. So let's just say CV4. Regardless of presentation, CV4 is applied.
So it doesn't matter what they're presenting structurally?
Because what you're trying to assess is the impact of CV4 on the heart rate and blood pressure, on the autonomic system. So the classic discussion focuses on treatment should be bespoke to presentation, right? Is that essentially the angle that you're thinking?
I'm just trying to get a grasp of how the experience laid out, right? So it doesn't matter what the person's presenting. You'll do prone oscillation.
Yes. Yes.
Doesn't matter what the person's presenting. You'll do and measure.
Yep.
Okay. I'm just trying to
absolutely. Yeah. And that's why I ask questions to make sure that I'm getting your question properly. Because otherwise I'm like, we just start talking past one another. But with respect to, say, what Liz is doing, checking the shoulder girdle, depending on the presentation of the shoulder girdle, you'll treat unique to the presentation, correct? Preston, same deal. You identify restricted shoulder girdle, treat either shoulder girdle or restricted hip, and then see what the difference in range of motion is. So far, did you get any more done?
Yeah, there's a couple more done. So far, there's been change regardless of what I treat, but there's more change treating locally than there is treating locally.
Which is what you would expect. Right. Awesome. So depending on this particular experiment, at least in the case of the ones we're talking about, yes, it's regardless of presentation. How it's applied is going to still be unique to the interface between the practitioner and the patient, right? So when you do CV4, you can't do CV4 one way. You have to do it the way that you're responding to that person, because the idea is that you're following the sensation that you're feeling in your hands, right? So now the neck, say with the neck treatment, it was completely dependent on presentation. It was, I want to see what treating the neck based on presentation is going to do to heart rate and blood pressure. So if presentation mattered as much as we would like it to, we would hope to maybe see a larger impact on anything that we would measure on account of it was unique to the needs of the patient in the moment, right? So one of the back and forth that can be had with respect to attempting to perform hands-on manual therapy, osteopathy specifically, is, well, you can't do the same treatment to different people and expect an appropriate result because the treatment has to be unique. And what I would say is you can design the experiment to take that into consideration. CV4 is a little bit less clear because you're just kind of holding the base of the skull, but treating the neck is more clear. It's like, no, I treated the neck based on how it presented. I'm treating the shoulder girdle based on how it presents. Does that help?
Yeah, no,
okay.
I understand what you're saying. I'm
cool.
just trying to,
yeah.
You're telling me this, and I'm trying to see just how to kind of gauge that information.
Awesome.
Where I'm looking like, let's say you did a global focal local treatment, right? Or did you just go local to the spot, right? I'm trying to wrap around my head like what is actually happening, what you're actually talking about.
Yep, for sure. So
how it was done. Right?
Yeah.
So,
in the case of CV4 and the neck, it was CV4 just applied to base of skull, neck applied to region of the neck based on need. Right? Whereas the shoulder girdle, it will again be full assessment of shoulder girdle to then see what the heck happens. There are other experiments where people are doing a full assessment or a full assessment of, say, in anatomy trains, you've got the superficial back line, so base of the skull to the heel, or maybe the bottom of the big toe. I don't remember for sure. I think it's the bottom of the big toe. And then they'll apply treatment to a specific spot. So they'll record all the findings, they'll apply treatment to a specific spot to see if changing that spot changes the line. Right? So it would depend on the experiment, and hopefully the fact that I say it depends on the experiment actually helps what you're trying to wrap your head around.
Okay,
sweet.
Just in terms of the data you're giving us, for that you just were giving us, I was just trying to get an idea
awesome.
of that.
Yeah.
What you were saying,
yeah.
The information you were presenting, I was trying to wrap my head around that specifically.
Yeah, and I apologize that it takes so many words to make it seem like I get that you get what I'm saying.
No.
It's all good, bro. So yeah, we want to have some idea that it's not going to harm and that it's going to benefit in the way that we want. What it then does, what all of the data collection across time seems to be saying so far, it's a very short period of time, but that it matters where you treat, it matters how you treat, right? So wherever you treat, you're likely to have a larger impact than if you're farther away from it. And that lines up with first do no harm and then do something good, right? So if I wanted to change what's happening with the shoulder, if I use the hip, it will change sometimes, but it may not change as much as I want, right? So then why would I do something like that? Well, if the shoulder is really tender and the person is very guarded, maybe I'll treat the hip that's restricted to see if it changes it and they get less guarded, right? But I won't expect it to do everything I want. I'll expect it to do something, right? If I want to do something to measures of nervous system function or a portion of the nervous system and the functions that are related to it, then I need to know what I'm trying to do and where I have the best impact. Right? So far it seems like, head to base of the neck does something reasonable for what we will term proxies for the autonomic nervous system. Right? So it's like, okay, well, it matters where I go. Well, that's cooler. Then what it also allows us to do is consider that with the normal variation in how people respond on things that we can easily measure physiologically, we can't control it properly. We can't trust that it's going to go consistently the way that we want. So we might be better off letting that sort itself out and focusing on motion. Right? So the classic line from Dr. Still, find it, fix it, leave it alone, and nature will kindly take care of the rest, seems to apply pretty well. It's like my job is to change the motion. If that is the reason they're having whatever thing they're having that they're telling me about, they're concerned about, if it's because of what I find that's not moving, they'll change together. Right? So the hope is to give you some insight into why we want to be really careful with talking about what these things do to processes, because we have some reason to believe that it's variable, or we have some reason to believe that it does something with relative consistency, but not big. Right? So if somebody comes in and they've got some kind of issue that seems to be related to the autonomic nervous system, say maybe they're a little bit more anxious, because what some people can do is take the information and say work on the base of the skull or work on the neck to increase parasympathetic activity and to drop heart rate and blood pressure, therefore I should be able to treat anxiety. It doesn't support that, right? It just doesn't, unfortunately. One of the reasons it doesn't is because to whatever degree anxiety is produced, or say any psychological state is produced by internal sensations, our ability to grab them and target them is not strong, and it's probably not directed enough. Because a lot of what's happening is you get internal sensory information. It goes up to your brain. Your brain will interpret it based on previous experience, and then what you're doing is you're predicting how you should respond. So if you usually get scared of bees, when you see a bee, you're not going to all of a sudden not get scared of bees, right? So to be able to target internal processes is a big challenge. And at least with what we're showing here, it seems to support the argument that it's a bigger challenge than many of us would be taught in the normal education process in osteopathy, right? Or the education process that you'd see in a bunch of places based on the types of claims that they make. Because I've heard in many places, yeah, this will do this, and this will do that. And, it's the kidneys, it's the liver. And I'm like, I'm not as convinced, right? So if it does show up that that's the case, that any of those things are the case, we'll have the data to show it. If it doesn't, we'll have the data to show it. Yeah.
Another question, just
please.
Went to my head. Are we looking at a singular treatment, or are we looking at a collective of treatments to effect?
So in the case of what I'm talking about, it's singular. Okay. And the rationale there is what you want to do first is figure out if there's any signal to start with. If there's some signal to start with, then you would do it over time. So let's just say you wanted to do something and compare the impact on heart rate and blood pressure from osteopathic treatment to something else. Then what you would do is you'd run it out longer, right? So it's like, okay, I have reason to believe that doing CV4 is going to have a positive impact on heart rate and blood pressure. Let's see what happens across time, right? So that's the one, or treating the neck. I would choose those two if I wanted to see what the heck happened to heart rate and blood pressure. I wouldn't, based on the data from prone oscillation or treating the thoracic region or treating the hip, I wouldn't choose to rerun those multiple times to see what it does, because there's no starting signal, right? So in the case of those ones, it's one treatment to see what happens, and if you get a positive signal, and if you want to run it again, then there would be value, right? So there would be value in seeing what happens with heart rate and blood pressure, treating CV4, treating the base of the skull, or treating the neck. There'd be value in it, but I don't know how big it would be. One of the things that you will see across time is diminishing returns. So if whatever the mechanical thing you interfaced with gets better, then you would actually, over time, expect the result to drop off. So like a dose response curve. So if I actually get the neck to work better, then each time I treat, I would expect that I would see a smaller drop, right? But that could be wrong. There's only one way to find it out, and that's to rerun it. So it's a good question, and it would just take time to run it. Yeah. Does that answer properly?
Yeah. No,
okay. Sweet.
Again,
yep. Yep. Absolutely.
The parameters.
Yep. Yeah. One of the challenges when you're discussing anything is that you've done a bunch of stuff. So when you talk about it, you're like, yeah, I'm talking about it clearly. And the questions actually help the discussion because those aren't things I said specifically. So it's a good question for everybody because you're the one that thought about it and asked, right? Yeah. So all that said, the thing that we'll work on is working in the region of the head, but we'll work on the things that you can meaningfully identify and meaningfully change. Usually, in most cases, that's the facial structure. So the TMJ obviously moves a ton. A lot of people will report TMJ problems. We want to work on that. We want to work on the facial structure and try to do it in more ways than I tend to classically do it. I tend to classically do it passive, and I tend to do it in more or less the coronal plane, but you can do it other ways. So we want to experiment with that and try to make that happen, especially patient active, because patient active makes a lot of that easier. If you want, we can mess around with a heart rate and blood pressure monitor. We can mess around with a cuff if you want to try any of that stuff and see if it does anything. All right, like we can do it because we have one here. But for the most part, we'll work through TMJ, we'll work through the facial structure. And especially if you want to use heart rate and blood pressure, we can actually mess around with the SCM. Right? If you're interested in measuring it. If you're not, who cares? It's more about the technical skills. The things that you're probably presented with most of the time are going to be people with things like sinus complaints, right? And things like TMJ complaints. And when you have either one of those, often you have the other thing. So they end up being pretty meaningful. Yeah. Yes.
When I was in
Yeah, the dead man's pose.
Yeah.
Yeah, no.
Do that ever? Like I've never done that to a single client.
It's not going to do what you want. So I think it's Dane Tasker's book. So Dane Tasker, I think it was 1917. I think that's the year it was. He has a picture really, really close to the end. And you can find, I have a video on this. It's treating the terminals of the fifth. So V1, V2, and V3. Okay. Only for the Star Trek fans. Now, I know it's Star Wars Day. It's May the 4th, right? But yeah, it's the terminals of the fifth. So sensory, motor, right? V3 is sensory motor. The concept being that the specific nerves will reflex back into the ganglia, the cranial ganglia, which I forget the names of, except for pterygopalatine, because that's snot and tears, right? So the concept of that was based on the fact that we think this does this. If I go here and irritate it for 2 minutes, I should be able to pull blood superficial. They didn't understand properly the concept of local autoregulation of blood flow. So I am from the GTA. I'm from the Greater Toronto Area. I was born in 1981, so there's a very specific thing and the term is Indian sunburn, right? So has derogatory elements, but you grab somebody's forearm and you just do this, right? It's friction based, and then blood flow changes, right? So I just call it giving people noogies, right? Like if you want to move blood, you can simply do it by irritating an area. You don't have to aim for a nerve terminal. The nerve terminal would rely on this always does this. The problem with tracing a nerve, first of all, finding it properly in somebody, because you can't properly observe it. You can observe some of its functions by proxy, like heart rate and blood pressure as an example, but you can't really tell that you're on it. You can't really tell that you're doing what you want to do. How would you know there's more blood? Well, the only way you would know is if it changed its temperature and you're thinking that that's more blood flow, because it probably is, or it changes its color, right? Like, and sometimes it does and sometimes it doesn't. Like, it's hard to know, but invariably, if you give somebody a noogie, it'll change, right? Because you will irritate the area which will call for blood flow. So yeah, to do something to the parasympathetic system there, whatever, good luck. We could, you could set up an experiment and see if it does that, right? But what you would have to do is, in that case, you'd have to differentiate it from just laying on your back, right? Sometimes it's just nice to lay on your back because you get close to naps. So I don't know. That one specifically, going after V1, I have no idea. Because I haven't looked at it, I haven't experimented with it, but I have reason to believe that other stuff does something. So yeah, no, that one, no. Yeah, please.
With the sinuses, I understand, right? There's air pockets in the skull.
Yeah, they're not air pockets; they're holes.
Well, holes. Yeah, you're right. Fair.
In the bones.
Why does it tends to go towards vibration? Vibration.
Yeah.
Tapping, whether you're rubbing. Is that just kind of like you're just shaking things loose?
It's an assumption.
Okay.
Right. So, I have had positive report from just working the facial structure, not doing any form of rubbing or tapping for the sinuses. With children, like with little children, the easiest way to drain their sinuses is to sit them up. So you get the baby with the runny nose, you sit them up and they get way better, right? So you're just using positioning in that sense. I've had, again, positive report from treating the facial structure. I don't know to what degree that's as valuable as I would want it to be. Like, I actually don't know, but I do know that I've done it and something's happened, at least with what they say. The classic methods will be irritation and tapping. Irritation being the assumption that what you'll do is you'll create, blood movement. If you create blood movement, you should create movement of boogers, I guess. Right? So I'm like, I don't know. Have you had the experience of somebody working on your sinuses with vibration or tapping and feeling extraordinarily better or noticeably better?
No.
Has anybody done it to you?
Yes.
And it didn't do anything?
I can't. It just made my face feel tingly.
Yeah, which might be nice.
Maybe, yeah.
Right?
But I can't say I can magically breathe.
Yeah. So again, I've had positive results more from treating the facial structure and whatever the heck else I find, especially. I did have one person who very early in my career had consistent sinus infections, and the thing that was the most restricted was the the top of the thoracic region, so kind of ribs 1 and 2-ish, with ribs 1, 2, and 3-ish. They had a hard time breathing consistently. We got those moving across time, and there was a much lower incidence within a year of, like within a calendar year of needing any medication for it. So went from an average of 7 to 8 sinus infections that were medicated in a year to, I think it ended up being 1. Right now, do I know that that's absolutely the case? Not absolutely, but I have a positive report, right? So what that supports, though, is you treat what's wrong, not treat what the person's talking about, right? Because unfortunately, I can't feel what the person's feeling, and what they're feeling is meaningful and real. I just can't target it. I can target what's not moving. Right? Good. Other questions? No, it's totally fine. No questions is cool. Okay, sweet. All right, cool. Let's do this. Turn this.